of Barrett's and even high-grade dysplasia or early cancer. So the first is when we have this nodule. So you can either have flat Barrett's, which is just changes in the tissue, but there's no elevation in the tissue. But you can also have nodular Barrett's, which you see up here. And so here's the Barrett segments that you're seeing here, and then here's this nodule. Well, what we're able to do is we're able to put a little cap on it. We suck up that cap, we put a little, like a lasso around it, and we cut it off. And we're cutting it off down to the second layer of the esophagus so that you're getting a complete resection. This is called endoscopic mucosal resection. And this is being used in the esophagus. It's being used for gastric or stomach tumors. We're using the same concept in the rectum and the colon. So it's useful in these nodular or raised lesions, and when paired with an ablative technique, you're achieving almost a 75 to 100% response. And so obviously we do this, and then we go back and we survey it, and we make sure that there's no Barrett's left in this area. So now we get to these ablative techniques. So the first technique that really came out was this, what's called photodynamic therapy. And the concept was you're destroying tissue using this light sensitizing reaction. And again, it's a very difficult procedure for patients because they would come, let's say on a Monday, we would inject them with this substance. They would come back on a Wednesday. We would do this procedure, which is fairly long. You're exposing them to UV light. And then, you know, it was very effective in getting rid of dysplasia, as you can see these numbers. But they had severe pain afterwards. They couldn't go out in the sun. And the biggest problem was they would develop narrowings in the esophagus, what we call strictures. This is what I actually, when I first did my training in this area, this is what I trained in. And towards the end of my training, radiofrequency ablation came out. And when this came out, this really revolutionized how we can treat this disease. This is a very simple tools to use and very short in treating. So the concept is, again, we use thermal energy to burn abnormal tissue. And then we scrape the abnormal tissue away, and then we burn it again. It's very safe. The majority of patients don't complain of any discomfort. Strictures or lacerations, all very, very rare with this. And this is a picture of how we do this. So this is the picture on the up top is someone with a long segment Barrett's, and you see different patches of Barrett's tissue. We blow up this balloon, literally takes several seconds, and we burn that tissue. And what you see on the right is what that tissue looks like after a burn. On the bottom, you see a very small area of Barrett's esophagus, and we have this little 1 centimeter probe. We apply it right to that area, we burn it, and it's done. And so we do these usually 2 treatments, and you need about, and 1 sitting, and then we bring them back 2 months later. We usually do another treatment, and within 2 to 3 treatments, all the Barrett's is eradicated. So in this large study that was in the New England Journal of Medicine in 2009, they basically showed that 127 patients, complete eradication of dysplasia and metaplasia achieved in about 90% of those patients that had low-grade dysplasia, 81% that had high-grade dysplasia, about 77% in those that had metaplasia or early cancer, and there was obviously less disease progression and less progression to cancer. And 5 patients developed some strictures, which we could very easily treat. 1 person had some bleeding, and 2 patients complained of some chest pain afterwards. So again, very effective therapy that we're able to do. And we know that when we combine this with the first thing I showed you, which was endoscopic mucosal resection, is extremely effective in getting rid of these lesions. Now, its competitor, which has come out over the last 5 years, is called cryotherapy. And cryotherapy uses this concept of liquid nitrogen to basically freeze the tissue and destroy it. The advantage of it is it allows for even a further deeper burn, which is also why it's a disadvantage. The other part of that's a big disadvantage is because you're using liquid nitrogen, you have to put a tube in the patient to get rid of all that gas because they're blown up like a balloon otherwise. But again, here's the pictures of it. You see a simple area of Barrett's there. You have this little catheter. You spray the liquid nitrogen. It causes a freezer burn of the tissue, and it destroys the tissue. Here's examples further on the bottom here. This has also been shown to be very effective in those patients with cancer. So it downgraded those patients with high-grade dysplasia or cancer in about 70%. And so again, 80% of patients with intestinal or intramucosal cancer at 1 year. The risk of perforation, which is a hole, accidental hole in the esophagus, is a little bit higher with this because it is a deeper burn. Now, the one other part that I didn't leave on this was one other concept, which is endoscopic submucosal dissection, which is really sort of pioneered by the Japanese, where they're actually getting down to the last layer and removing early cancers. And this is now replacing surgery, and is really, I think, the future of where GI is moving to. So in summary, how are we currently treating patients with reflux, Barrett's esophagus, and dysplasia? Well, those that have high-grade dysplasia, I think that universally everyone agrees that some type of ablative technique should be undergone before ever even thinking about surgery. Those patients that have low-grade dysplasia and have had repeated low-grade dysplasia should also get some type of ablative technique. The bigger question is, what do we do with the majority of patients? The majority of patients, when I get these biopsies back, say they have Barrett's esophagus with intestinal metaplasia. Again, what that means is you have Barrett's, but you don't have any precancerous changes yet. And, obviously, the companies that make these products would love us to treat every single person that has intestinal metaplasia. But really, it's not been shown to be cost effective. So we sort of limit it to those patients that have a first-degree relative with Barrett's esophagus, those patients with long segment Barrett's, severe reflux disease, or any history of prior Barrett's-related esophageal cancer. And I believe that concludes my talk. Thank you.
I have a question. In lieu of this new care process where people are being now determined whether they're worthy to be treated or not, how is this going to affect age-wise what's going on as far as your surgery and your treatments?
Well, I think a couple things. I think one is that as we've seen the aging sort of population, we're seeing a lot more Barrett's, and we're seeing a lot more advanced Barrett's disease, and a lot more dysplasia and cancer. And I think that's why this therapy is so critical in treating these patients early.
But we're going to have a board which judges whether you're treated or not treated, depending upon age and your worthiness. So how is this going to affect your job?
Well, that's a big problem. Because the problem is, like I mentioned, most of us are developing Barrett's in your 40s. You're becoming, unfortunately, symptomatic by the time you're 60s. And then, cancer, whether it's colon cancer or esophageal cancer, rises with age. And so, this is the biggest thing we're struggling with currently with colorectal cancer screening. The current guidelines say you stop screening at 75, but we know that the cancer incidence of colon cancer dramatically rises in your 80s and 90s. Well, there's plenty of healthy 70-year-olds that may live till 100, So it's a big problem. And I think this is the problem with, Obamacare mandating what is the age cutoff. I'll give you another example. I see a lot of pancreatic cancer. Well, everyone keeps asking me, is there a rise in the incidence of pancreatic cancer? Well, probably not. But the fact is, people are living a lot longer, and so we're seeing a lot more of it. So I think, the bigger problem that I see is that technology is moving very quickly, and we have the ability to treat a lot of disease but are we going to be given the resources to do it? Now, I will tell you, just to, from an economic standpoint, we don't get reimbursed for any of this. This is no different. This is very costly equipment for me to buy and store and whatnot. But I get paid no more for this than if I just took a simple heater probe, which costs me $200, and burned your tissue. And that's where it's a big problem. Just like, if I take one biopsy or I take 40 biopsies, there's no difference in reimbursement.